Mobitz type 1 and Mobitz type 2 both are second degree atrioventricular conduction block. In this video we are going to discuss about the difference between these two. Mobitz type 1 second degree AV block is also known as Wenckebach phenomenon. This is named after the Dutch physician Karel Frederick Wenckebach, who first described it. Mobitz type 2 second degree AV block is also known as Hay block because John Hay in 1906 was the first to describe this specific type of heart block. Mobitz type 1 is usually due to the functional suppression of the AV conduction that might be due to the drugs reversible ischemia. Mobitz type 2 is more likely to be due to the structural damage to the conducting system that is seen in the infarction, fibrosis, necrosis. Mobitz type 1 usually due to the reversible conduction block at the level of the AV node. Mobitz type 2 usually due to the failure of conduction at the level of the His-Purkinje system below the AV node. The QRS complex are normal in case of the Mobitz type 1 AV block. The morphology of the QRS complex is depend upon the where the conduction block is located. In around 75% of the cases where the conduction block is located distal to the bundle of His, that produces a broad QRS complex. Remaining 25% of cases, conduction block is located within the His bundle itself that produces the narrow QRS complex. Mobitz type 1 is produced by progressive fatigue of the AV nodal cell. Thus, there is progressive PR prolongation and then there is a skip bit. Thus, there is a warning sign. But in case of Mobitz type 2, it is all or nothing phenomenon, whereby the His-Purkinje cell suddenly and unexpectedly fail to conduct a supraventricular impulse. Thus, there is no warning sign. Mobitz type 1 usually benign rhythm causing minimal hemodynamic disturbances with low risk of progression to third degree heart block. In case of Mobitz type 2 is much more likely to be associated with hemodynamic compromise, severe bradycardia, and chances for progression to the third degree heart block is much more. In case of Mobitz type 1, the asymptomatic patient do not require treatment, but symptomatic patient usually respond to atropine. Permanent pacing is rarely required. But in case of Mobitz type 2, patient need immediate admission for cardiac monitoring, backup for temporary pacing, and ultimately insertion of a permanent pacemaker is required. ECG findings in Mobitz type 1, PR interval lengthens progressively until ventricular beat is dropped. In Mobitz type 2, PR interval is usually normal in duration and constant in length. In Mobitz type 1, PR interval shortens after dropped beat. In Mobitz type 2, if the PR interval is prolonged, the duration of prolongation is fixed. In Mobitz type 1, RR interval after the blocked beat is always less than the twice the RR interval of conducted beat. But in Mobitz type 2, RR interval of conducted beat is always constant or a multiple of a basic RR interval cycle length. Effect of carotid sinus pressure. Degree of block may increase in type 1 Mobitz block, whereas there is no effect for the type 2. Effect of atropine frequently shortens the PR interval and increases AV conduction for Mobitz type 1 block, where there is no effect for the Mobitz type 2 block. Mobitz type 1 block is usually a benign entity with minimal hemodynamic disturbances. But Mobitz type 2 is a serious condition. The risk of asystole is around 35%. The onset of hemodynamic instability may be sudden and unexpected in Mobitz type 2 that causes syncope or sudden cardiac death.